Well, thank you for coming. Obviously, the topic here is shock. So just going through the basics of what is shock. So shock is something that occurs when a disease process results in inadequate perfusion in various different ways. The poor perfusion is going to lead to a decrease in the amount of oxygen and the amount of nutrients that gets supplied to the tissues. And then that inadequate oxygenated blood flow leads to tissue hypoxia, cellular death, organ failure, all the things that would happen when tissues don't get what they need. So to make it really simple, shock is essentially just a state in which the body's tissues aren't getting the oxygen and nutrients they need to function normally. Well, using this, there's a lot of different types of shock that we potentially see. So there are four major types. And so if you think of them kind of umbrellas, and then there's multiple different types in between most of them. So the four major types, you've got hypovolemic, distributive, cardiogenic, and obstructive shock. So hypovolemic is something, and is a shock that occurs when there's a reduction of effective circulating volume. Distributive is one that occurs when there's a maldistribution of the blood flow caused by vasodilation. So those vessels relax, and then blood flow is going to places, but it's not going to the places that you want it to go. Cardiogenic shock occurs when there's a reduction in cardiac output from some type of a cardiac origin. And obstruction shock is associated with some type of a physical obstruction, whether it be cardiac or pulmonary. So we're going to break each of these four types down in talking about the examples of each one and some signs and symptoms you might see and some treatments that we may encounter with each. So the first that we'll talk about is hypovolemic. So hypovolemic, it's an emergency condition in which either severe blood or other fluid loss makes the heart unable to pump enough blood around the body. So when you think about hypovolemic, it's a tank is empty kind of a problem, right? Everything else is working normally, but there's nothing in the pipes to be able to move things through. So that tank is empty. Blood carries oxygen and nutrients to your organs and tissues, which we've kind of talked about already. So when that blood volume starts to decrease, whether it's from bleeding or a loss of fluid, and there's not enough blood in circulation, the heart can't be an effective pump. You can only pump so much out if you don't have anything. It's like turning on a fire hose, you don't have any water coming out of it. It's not going to do you any good. So if your body can't keep up with the loss, and this perfusion starts to worsen, organs start to fail, and symptoms of shock start to occur. So when you think of hypovolemic shock, there's two major types, either hemorrhagic or non-hemorrhagic. So if we think of hemorrhagic, here are some things that we might think and see. All right, so in hemorrhagic hypovolemic shock, the body loses about 1/5 or more of the normal amount of blood in the body. And there are many potential causes of hemorrhagic shock, right? So on the left, you can see in trauma. You can have internal and external bleeding in trauma. An arterial bleed can cause blood loss really quickly, but so can venous bed injuries, such as severe scalp lacerations. I mean, if you have a severe enough scalp laceration, I had a patient one time had partially scalped the entire right side of his head, and it was really difficult to get in there to get pressure and be able to actually apply pressure to the entire vascular bed. So no matter how much we packed into it, quick clot, regular gauze, it's not like there was anything obviously that you could tourniquet, right? You can't really tourniquet that. So it was really challenging, and it got to the point where we were questioning, do we need to actually transfuse him because of the amount of blood that he's bleeding from this scalp wound, which was mostly venous, but it just wouldn't stop. So even the small things that you don't really necessarily think of as being your big exsanguinations can cause some pretty severe problems. Internal bleeding can be pretty insidious. The major sites of internal bleeding. So if you think of blood loss in general, you know, we obviously have the external. I think that's easiest for us to recognize because it's easiest to see. But internally, the biggest areas that we can lose blood are our chest, our abdomen, our pelvis, and in our long bones. And we can lose a lot in all of those different cavities. But if a patient's young and healthy and otherwise able to compensate for a short period of time, we might not be able to see that right off the bat. When you're working pre-hospitally or even in the ED when a patient first arrives, you're not going to have the luxury of imaging and labs and all sorts of stuff to tell you, oh yeah, look, they have a huge retroperitoneal bleed. You've got to really, you know, do some good assessments and figure out what's going on potentially internally. And bleeding can stem from medical cause, as you can see the picture on the right. GI bleed is a really common one that we think of. Ruptured ectopic pregnancy is one that I don't routinely think of, but can elicit some pretty severe blood loss. So just kind of keeping in mind that there's a lot of different ways that a patient can be in hemorrhagic hypovolemic shock. And so what might that look like if we were to see that? So here is a diagram that just shows the classes of hemorrhagic shock. It kind of breaks it down into 4 major categories and allows you to actually quantify what class of shock they're in. The severity of the hemorrhage is definitely going to impact the level of shock the patient experiences, right? So this chart is just going to help you to show that to show changes that you'll see in the patient based off how much blood that they lost. So you might kind of be able to like figure out how much maybe they lost at the scene. So say you work pre-hospitally, I don't know, something happens in somebody's house, their family pulls them outside, you never go into the house, and you see that they have symptoms indicating that they might have lost up to 2 liters of blood, but you don't see 2 liters of blood, you know? So it can kind of help you a little bit that way. And it can also help you by just staging how concerned do I really need to be for this person, right? So you can see that as the blood loss worsens, the heart rate and the respiratory rate increase, right? And why is that? Your body's trying to increase its cardiac output. So it's trying to increase its heart rate, see, well, maybe if I get more blood around, then things are going to get better. Your respiratory rate increases. Maybe if I try to keep up, I'm going to try to compensate. My body's starting to become acidotic because I'm in a shock-like state. So I'm going to try to keep things going. So you're going to see both of those increase. And you typically see them increase in most types of shock. Blood pressure decreases. Again, something that you see in typically most types of shock. Urine output is something that they have on here. As your level of shock worsens, your urine output decreases. Obviously, pre-hospitally, or when a patient first gets into the ED, you're not necessarily going to see that. You know, you could put a Foley in somebody when they get to the ED and have a liter out and then have them transferred, and you never actually get to see any type of trends. So for some things that are really helpful, mental status, I think, is a great one. It's a huge indicator as to how well our tissues are being perfused. So use what you can, what is easy to identify and easy information to get in order to try to help you determine how bad off this patient is with this level of shock. And then always be concerned with your confused and lethargic patients, because they are telling you without telling you that there's not enough of the good stuff getting to their brain to make them make sense. As that didn't really make sense, but we're going to keep going with that. So always try to keep this chart in mind if you can when you have a patient that you know is having some type of a hemorrhagic situation. And then what do we do for it? So how do we actually treat it? So the very first thing is you stop the bleeding, right? Let's not let the problem get any worse. So once that's under control, so through various ways, right? Direct pressure, pressure dressings, tourniquets, traction devices. If you maybe have a long bone fracture and you think that you could have bleeding into the thigh, say, and so you put them in traction. Pelvic binder, if you're concerned about an unstable pelvis, you can have a lot of bleeding into your pelvis if you have an unstable fracture. So we put a pelvic binder on. So whatever the bleeding is, we want to stop that first and foremost, because it doesn't really matter what we do later on if we don't stop it initially. So that is always the first thing that we need to do. And then once that's done, then we want to give them back some of the blood that they lost, right? So we want to start blood as soon as possible, especially when we know that there's been a large amount of blood loss. Fluids like saline can be a good bridge until you can actually get some product. But remember, saline has no ability to carry oxygen to the cells. So while you might be filling the tank, you aren't filling the tank with the fluid that's going to help to perfuse the tissues with oxygen and nutrients, because you need blood for that. So you know, if you're working pre-hospitally, you don't have access for blood, obviously fluids are going to be a good enough bridge to be able to get you to where you need to go to keep some level of perfusion up. But just kind of keep in the back of your mind, okay, you're 1, 2, 3 liters in. Now you're just starting to dilute whatever the patient has left. So that's where you want to go to your nearest facility, even if it's not a trauma center, so that you can get blood product. You know, when you come here, it's pretty easy for us to get blood in the ED quickly. If you're on a scene and you are not near a facility, or it's going to be a pretty long drive, or say prolonged extrication, then you can always call the local flight crew. So whoever is nearest would respond. And at DART and UVM, they carry blood. So these are the things that you just kind of want to keep in the back of your mind. How can I get this person to blood products as quickly as possible? Because we need to replenish what they've lost. And then when they come into the hospital, we need to remember that the H&H can take a little while to catch up to their actual blood loss. So sometimes, you know, I've seen patients where they're fairly healthy. They come in after a pretty traumatic sudden injury. We draw labs as soon as they arrive, or maybe EMS drew them and gave it to us when they came in, and we send them to the lab. And their H&H looks like it's stable. You look at the numbers and you're like, these really aren't that bad, right? When you draw it early in their care, but that doesn't mean that the person doesn't need blood products, and it doesn't mean that they're not continuing to bleed. It does take a little bit of catch up because your body is pretty good at trying to compensate. So just keep that in mind. If your patient presentation looks like they could use blood product and it's just a number that's not agreeing with you, trust your assessment and your sample history and all of the information that you have over just a number. And if you do get your numbers back and you see that you've got a hemoglobin of less than 7, that's kind of the magic number to say, I'm going to need to start doing some product. So that's all hemorrhagic. And what about non-hemorrhagic? So non-hemorrhagic is stemming more from fluid loss, not from blood loss. So you have blood, but you don't have enough fluid. And there's a decent amount of fluid in your blood. So it's not like it's just, red blood cells, white blood cells, kind of all of the things that you think of when you think of blood. There is a lot of fluid in it that helps to make it thin enough that it can flow, but also to help with the transport of nutrients, lymphatic system, kind of everything. So any condition that causes a loss in those body fluids, in turn cause a decrease in the blood volume, will cause your non-hemorrhagic hypovolemic shock. So some examples can include excessive or prolonged diarrhea. Severe burns are a really common way that you can use fluid, and that's why we give so much fluid in burn patients. Protracted and excessive vomiting, excessive sweating. You can see here, if you have a marathon runner who say has been, running, not drinking, can become grossly dehydrated. So those are all different ways that you could develop this shock. And what might that look like? So the signs of non-hemorrhagic hypovolemic shock are fairly similar, right? Heart rate and respiratory rate are going to increase, blood pressure and mental status decrease, kind of makes sense, right? Because the perfusion is starting to get worse. So blood pressure drops, your mental status drops because you've got less perfusion to the brain. So this chart kind of helps you recognize what are specific to signs of dehydration, so fluid loss versus your blood loss patients. So you can realize that they're in a non-hemorrhagic hypovolemic shock versus potentially a hemorrhagic. And I'll be honest with you, sometimes we've got older patients that say come from the nursing home, right? Maybe they have confusion. They don't have a great story. You didn't get a lot of a report from the facility when you picked them up or when they arrived into the ED. And so you're looking at them thinking, okay, well, I don't really know, right? They're confused, but they're confused at baseline. So I don't know if this is necessarily a change. Their heart rate, they might be beta blocks. So maybe you're not seeing a big change in their heart rate. Their respiratory status, sometimes you can kind of, rationalize why that might be a little high. Their blood pressure being a little low. You might be thinking, could they be having a GI bleed? And I just have no idea. They haven't been here long enough to really be able to assess that. We haven't been able to guaiac anything. So this is something that can kind of help you when you start looking at the eyes. Do they have tears? What does their mouth and tongue look like? Is it super dry and cracked? Or is it moist? What's their skin turgor? And does that go back? Do they have the tenting where when you pinch the skin, it stays pinched, or does it go back pretty quickly? So when you don't have a great story and a great background and you can't really do a super great assessment, this can kind of help you to determine a little bit if you potentially could have a patient that's dehydrated. And then how do we treat that, right? We give fluids. So it's kind of like with the hemorrhagic shock, we want to give them blood to fill the pipes. Now we want to give them fluid to fill the pipes because we know that it's not a blood loss problem, it's a fluid loss problem. So we can do either saline or lactated ringers, kind of depends on the patient's background, other comorbidities, sometimes on some of their labs. But the important thing is just getting something started. If you are concerned about giving fluids, say you have a patient that's has a history of heart failure and you're just like, well, I'm a little worried about giving them a whole liter of fluid as a bolus. Maybe you start with 250 or 500 mLs and just see if you can start seeing an improvement in some of their symptoms, maybe an improvement in their mentation. This lecture doesn't really focus on pediatrics very much, but I found that most of the kids that I transported, this was one of their primary problems, is that they were dry and they started to get, listless, lethargic. They had either had diarrhea or protracted vomiting, hadn't been eating, hadn't been drinking, hasn't had wet diapers in several hours. And so this was something I noticed more in kids, how much they perked up when they would get fluid boluses. But it's such in the grand scheme of things, it's such an easy fix. So if it's something that you think could be going on with your patient, it's a fairly easy way to do a quick definitive diagnosis or a differential diagnosis to say, you know, I think it might be this. So let me just give a little fluid. Hey, look, I have improvement in my symptoms. I'm going to keep kind of moving down this track. All right, so those are our hypovolemic shocks. Now we'll go into distributive. So distributive is a type of vasodilatory shock. So it is a pipes problem. You've got plenty of fluid in the tank, but your pipes aren't working. So it causes inadequate tissue perfusion because there's this systemic vasodilation that occurs that leads to a decrease in blood flow to your brain, your heart, your kidneys, that causes damage to your vital organs. And so there's three major types of distributive shock that cause this vasodilation: sepsis, anaphylactics, and neurogenic. So we'll start with septic shock. So we did talk about sepsis a lot last month in the videos on YouTube, if you haven't seen it. But septic shock is a life-threatening condition in which the body has this overwhelming response to an infection, and that causes massive inflammation, massive vasodilation, and that worsens tissue perfusion and causes tissue and cellular death if it's not treated, right? If you vasodilate everything, so all your blood flow goes to your periphery, and you've got nothing centrally, and all of those organs that need everything centrally aren't getting what they're needing, then you start having tissue hypoperfusion, and then you start having tissue death. So what do we see in these types of people? You can see here that these are kind of the most common signs and symptoms of sepsis. Some of them you can tell are a little similar to your hypovolemic, right? Your fast breathing, elevated heart rate, maybe confusion. But then there's other ones, the weakness and aching muscles, feeling hot or cold, feeling very unwell, worse extreme pain, feeling the worst ever, potentially skin rash or clammy, sweaty skin. I mean, there are a couple of things here that are definitely different from our hypovolemic shock. And the big thing that I can tell you with sepsis is do your Q-SOFA criteria. So we talked about it a little bit last month. The Q-SOFA criteria is your quick assessment to be able to see if a patient could potentially have sepsis. There's a longer SOFA criteria that's usually used in the ICU, and it involves a lot of different labs and different pieces that you would actually have to trend. But a Q-SOFA is really quick. It's respiratory rate greater than 22, a GCS of less than 15, or a systolic of less than 100. You have two or more of those, and then that's going to make you need to trigger a sepsis alert and start moving down the sepsis algorithm, saying that there's a high potential that this patient could have some type of a septic problem. So if you can remember Q-SOFA, that's probably the best version of assessing your patients, is using that. And then what do we do if we say, yeah, you know what, I have the elevated heart rate, I have the elevated, respiratory rate, my GCS is 4, it's only say 12, and my blood pressure is really low. So yeah, I meet all the criteria for Q-SOFA. I think that's what this is. What do we do? So if we remember that a distributive shock is a kind of vasodilation, so a vasodilatory shock, then we can recognize that we need to fix that problem specifically, right? So of course we want to draw blood cultures early so we can figure out what the right antibiotic is. So that needs to be, you know, somewhere up on that list, but we really need to focus on getting them some fluids, seeing if maybe we can improve their perfusion status with just a little bit of fluids. And if that doesn't work, say we give a liter, maybe 2 liters, and we're getting into it and we're like, you know what, we're just really not seeing an improvement with a little extra fluid in those pipes, then maybe we need to give the pipes a squeeze, right? Because all of that inflammation that occurs in sepsis that causes that vasodilation, well, maybe the body just needs a little bit of help to tighten it up again and be a little less vasodilated. So then we want to consider doing some type of a pressor to give it a little squeeze. Usually the first thing that we seem to go to is Levophed. And so if you have that available to you to be able to start, it's a great one to go ahead and get started. And it's just going to give a little squeeze to that vasculature to reduce the severe vasodilation that the sepsis caused. But we want to try to reverse that cause of the shock, right? So if it's vasodilating, let's give it a little bit of a squeeze. What about in your anaphylactic shock? So your immune system produces antibodies that defend against foreign substances and irritants, right? But when the body's exposed to an irritant, it reacts to the histamine released by the cells damaged through the immune response during that exposure. So when somebody is allergic to something, their body releases a lot of IgE antibodies, and histamine is also released. And what does histamine do? Well, histamine dilates blood vessels, making them more permeable, causing fluid to leave the pipes and start to flood into the fluid. That's why you get localized swelling of the tissue. And so that vasodilation is going to lead to low blood pressure and poor perfusion, which is exactly what shock is, right? It's a poor perfusion state. So you can see there's a couple of pictures here where there's definitely this localized swelling for sure that you can see. And what else might you notice? You know, some of these patients feels a little obvious at times, right? Because they have some type of a rash, or they have stridorous respirations, or they're wheezing. They've got hives, itchiness, they're flushed. You know, they might complain that they feel like they've got a lot of swelling in their lips and their tongue. And so these are all potentially things that you could see if a patient is in an anaphylactic shock. Usually, the symptoms present about 5 to 30 minutes after exposure to the irritant, and sometimes a little bit longer if it's been food, depending. I know that there's some people where they just have exposure to peanuts and they can go into a full-blown anaphylactic reaction. But other people, it can be a little bit longer after they've eaten something. So this is a good picture to kind of go through all of the different potential things that you might see. But it's considered anaphylactic shock and not just an allergic reaction when the patient has difficulty breathing, they're stridorous, and they have low blood pressure from the severe systemic vasodilation. If you don't have those three things, you could just be dealing with a pretty severe allergic reaction or a normal allergic reaction. But if you have those three things, so the respiratory difficulty, stridor, and the low blood pressure, you've escalated into this anaphylactic shock. And again, shock, it's just poor perfusion. So it makes sense that once we get into this category, low blood pressure, poor perfusion, that it would move us into a shock state. So what do we do for these people? Well, you know, it's obviously a medical emergency, right? Requires resuscitation, including airway management, supplemental oxygen, IV fluids, epi, we can give it IM, sub-Q, or IV, any histamines, steroids. I mean, there's kind of a whole package deal that comes with this type of a patient. So we want to make sure that the allergen or the irritant isn't still coming in contact with the patient. Because I had a patient one time came into the ED, and no matter what we did to treat them, it didn't seem to be improving anything. And then we realized that it was their laundry detergent that they were having a response to, and he still had some of his clothes on. And so, you know, nothing improved until we finally removed everything and kind of started from scratch, and then his symptoms started to subside. So keep that in mind if they're not sure what it is that they're reactive to. Most people tend to know if they know that they have a allergic reaction to something. Many people have EpiPens. They may have already given themselves an EpiPen before you even arrive or before you see them. So just kind of keep that in mind. Epi is usually the first thing that you want to do just because it's the fastest. I mean, you think about, sure, could your partner put supplemental oxygen on while you're giving them Epi? Yes. But how long is it going to take you to put an IV in or start fluids or give steroids and antihistamines and all of these other things when you can do something really quick like an EpiPen? So just kind of keeping in mind the other thing that the EpiPen is going to do besides relieve some of the respiratory distress, right? Reduce some of that bronchoconstriction, reduce some of the swelling and the congestion, is it's actually going to cause a little bit of vasoconstriction with the blood vessels. So it's going to give you that squeeze, and that's going to improve your perfusion. And that's the whole point of treating shock, is we're trying to improve that perfusion. All right, well actually one more, neurogenic. All right, so what is neurogenic shock? It's often a result of injury or trauma to the spinal cord. And when this happens, your body can lose function and stimulation of your sympathetic nervous system. The sympathetic nervous system is what maintains bodily functions such as raising the heart rate and raising the blood pressure. So when the sympathetic nervous system isn't functioning appropriately, it can cause this sudden and severe drop in blood pressure from a lack of tone in the vasculature. And that causes a sudden decrease in perfusion, i.e. shock, right? So here you can kind of see a little bit of how that moves through, but we'll talk about what some signs and symptoms that you may see. So one of the big things that you might see is this sudden hypotension, and that's due to sudden massive vasodilation, and you'll also see a decrease in your SpO2. You might see warm, flushed skin because the patient is so vasodilated, all of that blood just goes right to the periphery and right to the skin, and there's no ability for the body to constrict the blood vessels. And so it all just starts to pool. So you'll have really warm, flushed skin, which is different than most other types of shock where you see the cool and clammy and they look really not the right color. They're like I said, clammy. This you don't see. This is kind of a weird type of a shock because you tend to not see that. You see that warm, flushed skin and you might think, oh, okay, well, probably not in shock because they're pink. Most people that are pink aren't in shock, but these guys are. Priapism can occur due to the severe vasodilation. The patient is not going to be able to mount a tachycardic response to compensate for the hypotension because that sympathetic nervous system isn't working properly. So often the patient will be bradycardic. So this is one of the only types of shock where you're both bradycardic and hypotensive. Okay. If the injury in the spine is high cervical, they could have impaired breathing, they could have respiratory arrest due to loss of nervous control in the diaphragm. But again, we can differentiate the systems of neurogenic shock from other types of shock because there's the lack of the compensatory mechanisms that are usually triggered by the sympathetic nervous system, i.e. the heart rate going up. Or the skin, looking at the skin, you have that warm flushed. So what do we do? You know, there is this massive vasodilation again from the lack of the sympathetic tone, and the body can't fix it. There's nothing that it can do to compensate for it. So we need to do that for them. We need to bring that back tone, bring back that tone. So we do that with vasopressors such as epinephrine and phenylephrine. So phenylephrine is an alpha agonist, and an alpha agonist means that it essentially just gives you a really good squeeze in your peripheral vasculature. It doesn't do anything with your heart. All it does is really squeeze everything. And so if we can start something like that with this type of a patient who doesn't have any other cardiac related issues, they just have lost tone. So we do something like phenylephrine and we give them that tone back. That'll help you to raise your blood pressure. If they're still bradycardic, which they could be, you could potentially use atropine or epi. And we want to focus on trying to stabilize the patient and not cause any further spinal damage and transport them to definitive care. So obviously you're not going to have this type of an image if you're working pre-hospitally, but if you do an exam on a patient and you see that their neurostatus is really poor when it comes to maybe their lower or upper extremities, their CSMs are absent or abnormal, you've got the changes in your vitals, so the low heart rate, the low blood pressure. Those are kind of things that need to tell you, I think I could potentially have a spinal injury and I could be in neurogenic shock. Now, whether or not you decide to go to your local facility or go to your local trauma center, it kind of falls on your local guidelines as to what you would need to do. But being able to at least recognize that this is a potential problem so that you can pass it on to the next group, whoever you hand off to, so that they can proceed to either get imaging quickly to be able to transfer to definitive care or start treating appropriately, then that's a really great thing to be able to recognize this, to be able to give somebody that information. All right, cardiogenic shock. So cardiogenic shock, I kind of lumped into one big category. And it's caused by a condition in which the heart suddenly can't pump enough blood to meet the body's needs, right? So it's not a tank problem because our tank's full. It's not a pipe problem because our pipes are working. It's a pump problem. So the pump isn't working. So it's a type of circulatory shock in which there's insufficient blood flow and oxygen supply for tissues to meet their metabolic demands. And because the heart isn't pumping effectively, body can't get oxygen and nutrients, blood pressure starts to fall, organs are hyperperfused, they begin to fail. This is all sounding very repetitive, but you know, the most common cause of cardiogenic shock is an MI. But other potential causes include various cardiomyopathies, massive PEs, arrhythmias, so you know, ventricular fibrillation or ventricular tachycardia, because both of them are ineffective pumping of the heart, some drugs, different things like that. So here you can see some of those outlined as well. But yes, pump's not working, everybody else is fine. So what are we going to see in these types of people? The main symptoms that we encounter pre-hospitally in the ED are going to include clammy skin, arrhythmias, and hypotension, accompanied with a sample history that supports some type of a cardiac disorder. So additional tests are going to help to definitively diagnose the patient with cardiogenic shock, and that might include EKGs, labs, chest x-rays. An EKG with changes such as ST segment elevations or inversions and inverted T waves can clue us in that there's something occurring within the heart with a high suspicion for an MI. A troponin and a BNP can come back elevated, that increases suspicion. Chest x-rays can reveal cardiomegaly or pulmonary edema, which could help to establish this diagnosis as well. So it's essentially just what are things that could be making the heart not pump well that are in our differential diagnosis. And if we do come up with that and we say, yes, no, it does look like that they had a large MI and now we're going into cardiogenic shock, what is it that we do for that? So the treatment is focused on correcting whatever the underlying cause is and increasing the oxygen supply to the heart the best that we can. So in order to treat the underlying cause, we have to determine what the primary diagnosis is. So, we could do that 12 lead and say, yeah, it looks like they're having an MI, but it probably means going to have a cardiac cath done, right? Toxicology management if the patient has an overdose, cardiac surgery if they need a valvular repair. So in the meantime, since we don't do those things here, what is it that we can do to help to support this patient before they get to that definitive care? So we need to support the heart the best we can with oxygen, pressors, and ionotropes. And there's differences between vasopressors and ionotropes. So vasopressors induce vasoconstriction and help to elevate the blood pressure, which can help to improve your cardiac output. And that's great. That's what we want. Inotropes, so examples of that would be dobutamine or milrinone, can help to increase the cardiac contractility, so that squeeze of the heart. However, there's some medications that we call pressors, so you can see here, like Epi and Levo, that do have some of both of the properties. They both have some vasopressor properties and some ionotropic properties. And so those can be really excellent ones for us to use. And here we don't have milrinone. I believe we have dobutamine on the formulary, but it's not something that we routinely use. And with something like dobutamine, you can start it and think that you're going to have an increase in your blood pressure, like with your other vasopressors. You don't. Sometimes you actually see a decrease in your blood pressure, and you actually have to start a vasopressor to combat the effects of the ionotrope so that you can get them both where you need to be. And it's very much a balance game. And that's why most of the time it's not done outside of the cardiovascular ICU. And then once the patient is transferred to definitive care, it wouldn't be uncommon to see them go on a balloon pump or an impeller or some type of an assistive device to help the heart in functioning and to decrease the afterload to make it easier for the heart to actually pump the blood through the body. So take some of the pressure off of the heart, because that's our goal in a cardiogenic shock. We don't want to give them something like phenylephrine, like we talked about before, for a neurogenic shock patient, because what does it do? It just squeezes the periphery. And what happens when we squeeze the periphery? We see an increase in our blood pressure, so that number looks better. But now you're increasing the work that the heart has to push. So if I go from a vessel like this to a vessel like this, my heart has to push even harder to push the blood through that smaller vessel than it did through that larger vessel. And so what I'm doing is I'm putting more strain on the heart, I'm increasing the myocardial oxygen demand, and I'm making things worse. So we really kind of have to look at this and say, do we really need a blood pressure of 120, 130 systolic? Or can I be comfortable with a systolic of 90 with improved mentation and improved SpO2 and continue that way until we can get them to definitive care? So it's definitely a challenging one to work with, especially because we don't have the luxury of the assistive devices that they do at tertiary care centers to be able to say, oh, well, let's just go ahead and put an Impella in and it'll help to improve their forward flow, or use a balloon pump to help to decrease the afterload. We don't have that ability. So we really need to be, cautious and aware when we treat these types of patients, because moving too much in one direction is actually going to potentially cause more problems. All right, an obstructive shock. This was always one of my favorites. So obstructive shock is caused by an inability to produce adequate cardiac output despite everything else being normal, right? So there is normal intravascular volume, so your tank's full. The pipes are normal, so there's no massive vasodilation. Your pump is normal, or mostly normal. So that's not the issue. The muscle itself is working. So there's some type of roadblock or obstruction that's decreasing the blood flow and the ability to actually perfuse tissues. So there's some type of a mechanical obstruction, either to or from the heart. So there's three major types. We've got tension pneumothorax, cardiac tamponade, and massive pulmonary embolism. So we'll start with the tension pneumo. So you can see here in this lovely x-ray, if you look on this side, you've got, some like white, normal, patchy consolidate, not so much consolidation, that's not the right word for it, but you can see that you have this haziness here, that's your lung tissue, right? And then here you can see that it's nearly all black. And that's because that lung has collapsed. So a tension pneumothorax is a severe condition in which the air is trapped in the pleural space under positive pressure. So it displaces the structures of the chest by moving. If this lung collapses, and I start to fill with air in an area that it can't now escape, it's going to start to move across my chest and push on my heart and push on my opposite lung, right? And what happens when anything pushes on the heart, it doesn't allow it to expand and contract. So every time that it now pumps and more pressure comes in, it now can't expand back as big as it was able to when it had the full cavity to be able to work in. So that's an obstruction. So it not only puts pressure on the heart, but it also puts pressure on the inferior vena cava, so blood returning to the heart. So now we've got a decrease there too. So it really makes it hard for the blood to have any forward flow. And that leads to perfusion and big surprise, it leads to shock, right? Early recognition in this though is paramount. All of the other types of shock, for the most part, you could probably take a couple of minutes to say, oh, I think this is what's going on. Maybe not the bleeding, stop the bleeding, but then, you can have a minute or two. Not with this. This needs to be pretty rapidly recognized. And so how do we do that? So first off, what can cause it? It can be multiple things. Trauma is always kind of the first thing that we think of, right? Rib fractures, and it could be rib fractures from CPR, which is not extremely common, but common enough that it's something that you should think of. Any surgical procedure in the chest, let's say they recently had a central line placed, maybe they had a biopsy, pacemaker put in, had a bronch, and sometimes it can be idiopathic. So think of tall white male teenagers. I don't know what it is about that group, but there are several literature articles out there that talk about them having spontaneous pneumothoraces, and some of them ending up being tension pneumothoraces. So there's a lot of different causes. So the things that you want to remember when it comes to assessing your patient, and this is a pretty good example in this picture. So, kind of breaking it down, you can see, all right, apprehension, agitation. Yes, that is a big ding ding. Anytime somebody tells you, I can't breathe, things are getting worse, I can't get air in, I'm going to die. The I'm going to die should always trigger some type of a response or a further assessment. You might see some sub-Q emphysema. So you might have the sub-Q air where you can actually feel, and it feels like Rice Krispies. You can kind of almost like a crackle. You may have that, but you may not. So don't think, oh, my patient doesn't have that, so they couldn't have a tension pneumo. Signs of shock, such as the cold skin and clammy, they could, but sometimes if it's a really sudden tension pneumo, like say after a trauma, they may not have had time to necessarily develop that full clamminess. So don't go off of just that either. Breath sounds being absent or decreased. Again, it's a great example, but it can be really hard if you're working pre-hospital, you're in a loud ED, to be able to say, I need everybody quiet so I can listen to lung sounds. And lung sounds can resonate. So you can listen on one side, especially in kids. You can listen to their chest and listen to the left side and think you've got lung sounds. And it's really just because you're hearing us on the right and it's just resonating across, especially since this is now a big open space. And sounds can sometimes transfer a little bit easier. So distended neck valves, you can definitely see some JVD in these patients. Tracheal displacement towards the uninjured side. So this is a very, very, very late sign. We should have recognized something before this happens. And even the JVD is a pretty late sign, unless it was kind of a slow buildup and then suddenly they got to the point where it was starting to impact the cardiovascular system. But very rarely are you actually going to see tracheal displacement because it is such a late sign, because that means now that tension pneumo is moved up into the neck and starting to do some pretty significant displacement. So again, don't get too stuck on that one. But if you have a patient and you say, okay, they've got impending doom, I think that I have lessened breath sounds on this one side. I have something to indicate to me that they could potentially have a tension pneumo, whether they were a trauma or we just did CPR, or I mean, really any of the other reasons, right? Like tall, white, teenage male, and they're saying that they can't breathe, and you don't have breath sounds on that sound, or breath sounds on that side. So we just want to be pretty aggressive about the management. This is not a situation, if you think somebody actually truly has a tension pneumo and we're in the hospital, that you would necessarily want to wait for a chest x-ray to confirm. If they're non-symptomatic or non-greatly symptomatic and the provider wants to get a chest x-ray to determine what it is so that they can potentially place a chest tube and kind of decide what's going on, that's one thing. But if somebody is actually saying, no, I'm going to die, their SpO2 is starting to fall, they're starting to have absent lung sounds, that's not something where we have time to do a chest x-ray. So that would mean doing a treatment plan such as, I'm jumping ahead, okay, needle decompression and or chest tube. Needle decompression is really quite the quick way. And that's what we would do pre-hospitally, and it's what you could do if a patient came into the ED that was in extremis if you didn't have time to set up for a chest tube. So do whatever's in your scope of practice and whatever's faster, because it is a life-threatening emergency and the patient will decompensate and go into cardiac arrest without intervention. So in order to do a needle decompression, so you can see in this image here, there's two different places that you could do it. So you can go to your second intercostal space on your mid-clavicular line, and you need to pick a needle that's deep enough to penetrate through all of the layers of tissue into the pleural space. Most of them tend to be about 5-inch needles. And once you've placed the needle, you may hear a small rush of air. If it's loud, you're not going to hear anything. But more importantly, your vitals are going to improve and your patient condition is going to improve, right? That's what we're really looking for, not necessarily the air. I've seen some places where they'll say, take a flush and squirt out 7 or 8 ml. So you just have a couple of mLs of saline in there, put that on the end of your needle. So then that way, when you go into the pleural space, you can aspirate and you should see bubbles coming up, and then you're in the pleural space. If that's something that you've been taught or is within, your standard practice for where you're working, that's fine. I've never used that technique. I've always just gone ahead with needle in and go ahead and see if you have improvement in your vitals, and that's going to be enough to tell you that you're in the right space. The other thing that can be kind of tricky is skin thickness. And so what you can do is the needle itself is obviously very sharp on the end. So you can actually take the tip of the needle and use it to make a small little slit in the skin, just to be able to pass the needle with the catheter through, because the catheter itself is a little thick, it's a little bulky. And so sometimes when you're actually trying to get through all of that tissue with the catheter can kind of almost like stick on the skin a little bit and get caught up and make it more challenging. So if you do a little bit of a nick in that skin to make yourself a little bit more space, kind of like what you would do if you were putting a central line in and you just want to give yourself a little bit more space when that dilator goes in, it actually makes it a little easier to pass the needle. Or if you've got somebody that, say, has a lot of tissue up here and so you're really struggling, you could consider doing the secondary place. So that would be in the 5th intercostal space above the 5th rib at the anterior axillary line. And again, it can be somewhat beneficial in your obese patients because they tend to have a little bit less tissue in that anterior axillary line. So a couple of different options. If you do that, you just have to make sure that the arm is up and extended so you can actually really get good placement. And then anytime that you do a needle decompression, you do want to make sure that you go over the top of the rib, because along the bottom of the rib run the veins, arteries, and nerves. And so anytime we ever go into the chest cavity through rib, we always want to kind of glide on the top of the rib and never underneath it. Even though I know they're stacked, so it kind of seems counterproductive to say you can't go under it, but you just kind of want to glide up and over the top of it and try to avoid going right directly on the bottom. And then the other thing that we could potentially do would place a chest tube, right? So, typically we put it in the anterior axillary area. But there's sometimes where they'll decide to put pigtails in various places, especially depending on what else might be going on. But for something like this, for a tension pneumo, or maybe you did a needle decompression and then decided, all right, I'm going to put a chest tube in so that I can definitively treat this pneumothorax, you may see the placement slightly different. And once you have it placed, then you'll have to connect to some type of a drainage system. Sometimes you can see Heimlich valves. They're small devices. They're blue on one end and they're brown on the other. And it has like a flutter valve inside, so it lets air escape, but it doesn't let air come back in. If you ever have experience with that, just know that the blue goes to the patient. So the blue end to the blue patient is how we used to teach it. Otherwise, you're going to see this more traditional atrium setup. If you're not familiar with the setup, let me know, and I'm happy to do some one-on-one education. The hard thing with this system is just that it does always have to be standing upright. So if you're transporting a patient to another facility and they have one of these, it can just be a little challenging in the transport world because they're very easy to tip over and they're easy to crack because it's just plastic. So you really just have to be cautious about your placement, making sure that it always stays below the level of the heart so that we don't have any fluid potentially backtracking, because again, it doesn't have any valves in the tubing that's going to prevent any type of fluid from not backing up. And then there's a little bit of a setup. You've got being able to set what your suction gets to. You have to fill the chamber with water. You have to assess it and assess titling and bubbling. So there's a lot of different pieces with this. So if it's something that you haven't experienced and you want to do a little bit more on, definitely let me know. And it's something that I'm probably going to do a little mini video on at some point to be able to post just so people can have the practice and the refresher. All right, so we did our tension pneumothorax, which is essentially, the lung obstruction. So what about cardiac tamponade? So cardiac tamponade is caused by the compression of the heart due to a buildup of fluid, blood, or air in the pericardium, and that's the double-walled sac surrounding the heart, right? So normally the pericardium does have a little bit of fluid inside, and that prevents the two layers from rubbing together when the heart beats. In cardiac tamponade, there's the increased amount of the fluid, blood, or air, and so that leads to pressure on the heart, and so it can't expand properly. So it beats, and then it can't expand as wide as it was because now it's starting to be compressed externally within that pericardium. So every time the heart beats, less blood is actually pumped out. And so what happens when less blood is pumped out? We're in a low perfusion state. What is a low perfusion state? It's a type of shock. So this condition can rapidly progress to circulatory shock and cardiac arrest. Causes can include chest trauma, aortic rupture. So you can actually have, if you have an aortic tear that stems up into the heart, into the pericardium, then you can actually have blood loss into the pericardium. A ventricular rupture during or after an MI. So one of your ventricular walls actually ruptures. It can be due to long-term inflammation of the pericardium. It can be from some types of cancer. So there's a progressive buildup of fluid over time. Most of the time, I think we tend to think trauma, but it could definitely be caused by something medical. So keep that in mind when you're getting a sample history from your patients as to, could this actually be a potential? And what are we going to see in these types of people? So they have a multitude of symptoms, and a lot of them are kind of similar to some of the other types of shock, right? But anxiety, restlessness, so those should always clue you in something's wrong. Chest pain, rapid breathing, difficulty breathing, right? Because they're not getting that blood flow, so the lungs aren't getting what they need, and so now they're starting to feel like they can't get enough air because their body's telling them you're not getting enough oxygen. So the three most common things, though, to see with cardiac tamponade are known as Bex Triad. So that includes JVD, so jugular venous distension, muffled or distant heart sounds, and low blood pressure. All right, so your JVD occurs, why? Well, the body's having a hard time returning blood to the heart because now the heart's being compressed, so it's harder to get blood in and it's harder for the heart to pump blood out, right? So when it's hard to get blood in, the venous system starts to back up, and then that starts to engorge. What's the first thing that you see right off of the heart that's going to engorge in the venous system is your jugular vein. And so that's where you see that jugular vein distension. Now, the muffled heart sounds, they're due to the expanding layer of fluid or blood in the pericardium. So it's making it harder to hear the heart actually beat because now it's surrounded in this big bubble of fluid. So it's distorting the sound. Low blood pressure occurs because the volume of blood being pumped out is reduced because the heart can't fill like normal, right? So you can see all three of these things. And that's why it's called Bex Triad, because it really is the most common symptoms you're going to see with this type of a disorder. So what do? Well, some providers will say, let's just do a quick ultrasound of the heart so that we can assess and see if there's something going on. Other times you might see them say, let's get a CT. You don't want to forget to do a 12 lead. Okay, so in patients with cardiac tamponade, you might see low voltage. So as the large amounts of fluid builds, it actually diminishes the QRS amplitudes. And so you can see that on your EKG. You can also see electrical alternans, where the amplitude of the QRS complex varies from one beat to the next, but within the same lead. And that's due to the swinging of the back and forth of the heart within the sac. So if you think of it as this in this big water balloon, and then you've got the heart in the middle of it, every time it beats, because it's in fluid, it kind of almost has a little bit of free motion, right? And so that can actually change what you're seeing on your EKG. So you can see here how we have several beats, and the amplitude varies within the same lead. So that's electrical alternans. So that's something that should trigger you into thinking, well, there must be something with the heart, because the heart itself is moving beat to beat, which is giving me different amplitudes. I always thought that one was kind of interesting. So what do we do for these people? Well, there's two things that we need to treat, right? The first that we have to do is relieve the pressure on the heart by draining whatever is in that pericardium, blood, fluid. That's the priority intervention, and it can be done with the pericardiocentesis. So it involves taking a very long, large needle. A lot of times I've seen providers, especially in ED, use a spinal needle, because those tend to be some of the longest that we carry. And you enter the pericardium to drain the blood and the fluid, right? So you go right below the xiphoid, and you want to aim up towards the left shoulder. And then as you go, you'll aspirate. And then once you get into the pericardium, you should see that it would be easy aspiration. You should expect to either see fluid, so you might have like some serosanguine if it's a medical condition, or if it's blood, you should see dark blood. You shouldn't see bright red blood, because that might indicate that you actually went through the pericardium into the ventricle, right? Because you'd be getting bright frank blood. Usually it's a little bit darker because it's been sitting in that pericardium for a little bit of time. Again, this isn't something that we see terribly often, and sometimes it can be something that's done almost as a last effort in a cardiac arrest, especially after a trauma. And so it can be a little bit challenging to get that experience and seeing that. So that's the first thing we need to do, is that pericardiocentesis, right? And then the next thing that we need to treat is whatever the cause was. So if it was trauma, could have been a buildup of fluid from a cancer. And if so, maybe that was a slow buildup of fluid, so it's not something we have to worry about emergently. But if it was a trauma, or say a ruptured aortic aneurysm, well, that's certainly something that's going to be problematic for us. Either way, patients are going to need to go to a tertiary care center and have some type of cardiovascular surgery consult. So in the meantime, while we wait for transport to definitive care, or while we're transporting to definitive care, we need to make sure we give supportive care, which includes oxygenation, proper airway management, fluids, and medications such as pressors to help stabilize their hemodynamics. Try to improve the level of shock to the best of our ability to allow perfusion to tissues, given the situation that they're in. And then we've got our pulmonary embolisms. So pulmonary embolus, so a PE, is a blood clot that develops in some blood vessel, usually it's in the leg, breaks off and then travels to an artery in the lung, where it suddenly blocks blood flow in that lung, right? And this restriction of blood flow causes a decrease in the oxygen level in the blood, because now you're not able to get blood to that portion of the lung to be able to then ventilate and perfuse, so that we can exchange carbon dioxide and oxygen, and then we can get all that oxygen-rich blood out to the body. Well, what happens in a PE is it's blocking that transaction. So while the blood flow might be okay when it comes to the, the pipes are good, the tank is full, the heart is pumping, but the blood's not able to get to the areas of the lungs to actually replenish its oxygen. So when it goes back out into the tissues, it's still not oxygenated. So your tissues are still unperfused, even though it seems like blood's moving, right? So we don't have that fresh oxygen, tissues aren't perfused, we're back in that state of shock. And it's not just DVTs that can develop into PEs, right? There's a lot of different things that can cause PEs. We have long bone fractures can lead to fat emboli. Inactivity that leads to DVTs can break off into a PE. That's kind of one of the common ones we see within the hospital, especially long-term in the ICU. There's medical conditions that cause clotting disorders to make a person more predisposed to PEs. Some medications like birth control can definitely make you more predisposed to PEs. So there are a lot of different potential causes, but how do we figure out that that is a potential problem for our patient? Well, the symptoms definitely depend on the size of the clot and where it lodges in the lung, right? We see patients all the time where, you know, they're diagnosed with a PE and they're sent home maybe on nothing. Maybe they're just on, they're started on an anticoagulation medication and they have a follow-up in a month, you know, or there's somebody that's in full extremis or in cardiac arrest. So it definitely varies based off the size of the clot and where the clot lodges. Most common symptom, as you can guess and imagine, shortness of breath, right? It can be gradual or it can be sudden. You might also see anxiety, cyanosis, reports of chest pain, some irregular heartbeats, lightheadedness, rapid breathing or rapid heart rate. They could potentially cough up blood. If you did a 12 lead on this patient, because say they come in, they say, hey, I'm having chest pain, right? So chest pains get 12 leads. Well, you do a 12 lead, it most likely will show sinus tach. Sometimes you might see a new right bundle branch. You may see non-specific ST segment and T wave changes, including ST elevations and depressions. If you have simultaneous T wave inversions in your inferior leads and right precordial leads, so your V1 to V4, it is the most specific finding in favor of a PE. And there was one study that reported specificities of up to 99%, but it's also known as a right ventricular strain pattern. So it kind of makes sense, right? Your heart is straining because it's not able to get the blood to where it needs to go in the lung, starting to back up, putting strain and pressure on the right ventricle. Right ventricular strain pattern, common with the PE, right? Because you've got an obstruction in where the blood is trying to flow into the lung. You could be asked in the hospital to get a D-dimer, and a D-dimer measures a protein fragment that's produced when a blood clot gets dissolved in the body. Normally undetectable unless the body's forming and breaking down clots. And that's why we would run it in a person that we thought had a PE. So if it comes back elevated, then you may see a provider order a chest CT with contrast to rule in or out definitively if the patient has a PE. But your D-dimer can be elevated for a lot of reasons. So it's not something that's going to give you a definitive diagnosis, but it's something that you could definitely encounter as the provider is trying to figure out what's going on with the patient. We decide that they have a PE, and what do we do about it? So again, the treatment is kind of going to depend on the size and location of the clot, just like the symptoms depend on the size and location of the clot. So supportive care is always the priority. We oxygenate and we support hemodynamics. After that, there are definitely a couple of different options. So thrombolytics, which are our clot busters, can be used to speed up the breakdown of a clot. It's typically reserved for symptomatic patients because of the risk of severe bleeding. EPA is something that you could see commonly in this scenario. It does come in a sterile water vial and a powdered vial. And so what you have to do is you spike the water vial first, then push the powder vial on top. So you got clouds over water. And then when they're fully connected, you flip it so that they can mix. And then you would go ahead and, gently swirl it, draw it up according to the order. And do remember that because this is a huge spike, it causes a huge hole in the rubber stopper. So a lot of times it can be easy to take the medication and think, okay, I'm just going to draw it up and flip it upside down like we normally do with meds. And you have a lot of it leak out, and it is very expensive. So you certainly don't want to have it leak and lose a lot of the medication and have to get another set. So just be cautious and careful when you're doing it. And it comes with a really nice info packet in the medication box if you haven't had the experience of mixing it, that breaks down the steps really nicely. A patient can get put on anticoagulants to have it happen, to avoid it happening again. You might see them get transferred to a tertiary care center for clot retrieval in IR. If you think that they have a high potential of having more DVTs that could develop into PEs, they could have an IVC filter placed. And so you can see here, it's a little filter that gets put into the IVC that helps to trap clots so that they can't actually travel up into the lung. And so that can be something, it's not an immediate treatment whatsoever, but it's definitely something that you consider later on if you have a patient that's really predisposed to having this happen again. So how do you know what type of shock it is? I mean, we've talked about a lot. A lot of the symptoms are fairly similar, and some of them have very unique symptoms for sure, but there are definitely some underlying themes. So because there's so many types, we know that shock is a state in which the body is being poorly perfused and not getting the oxygen it needs. And it could be caused by a multitude of conditions. And sometimes it's very clear. But what if you can't clearly determine what the cause is? It can be hard to pick a treatment plan if you don't have a differential diagnosis, right? So if you're in that situation, you can try this trick. It's worked for me quite a few times when I've scratched my head as to what is actually going on with my patient. It was one of the nurses that I worked with that taught me this, and it's been really helpful. So quickly fill and squeeze the pump, and breaking it down into 4 different steps. And it kind of reminds you of how to go through it. So quickly, is the heart rate too high or too low? When your heart rate is too high or too low, it can decrease the cardiac output and make the patient go into shock. It can be a type of cardiogenic shock. We want to slow down if it's too fast, or speed up if it's too low, the heart rate, using our ACLS algorithms, and reassess. Did it fix the problem? Yes. Great. That's all that it was. They were in SVT, and so they weren't perfusing because their heart couldn't pump out enough blood keep up with that heart rate. Now that you decrease the heart rate, it's able to appropriately fill and cardiac output is improved. But what if it didn't? Or what if your heart rate's normal and you know that that's not the problem? Then you move to fill. So assess the patient's volume status. Are they dry? Are they bleeding? Are you not sure? Because it could be internal bleeding. So give some fluid. And if you think they're bleeding, give some blood. And if the patient doesn't respond to the fluids or blood, you don't see an increase in their blood pressure, you don't see an improvement in the perfusion or the mentation, then you can move to the next step. So we've dealt with the rate, we've dealt with the pipes, the tank being empty, and now we're going to talk about the pipes, right? So let's squeeze. So when we get to the squeeze part, think about adding a vasopressor, right? So, you know, if they're poorly perfusing and they have a normal heart rate and we filled the tank, so that's not the issue. Well, now we move to maybe the pipes are part of the issue. So starting levethet or epi can help to improve perfusion to the central organs. It can worsen perfusion to extremities at high doses, however, because of the vasoconstriction in an already poorly perfused area. So in the ICU, you'll frequently see that the poor perfusion can actually lead to some necroses in the fingertips and toes. But that's not an immediate problem, right? We have vital organs that we're trying to save. So that needs to be the focus. And so, you know, let's say you add levethet or epi. And, you know, maybe at that point you're like, well, it's still not really working. Finally, the pump. That tells you that there might be a failure in the heart itself. So that's when, if we were in a tertiary care center or a cardiovascular ICU, we could be considering inotropes like the Distributive or the milrinone, or consider transferring to a tertiary care center pretty quickly. So if you can remember this, quickly fill and squeeze the pump. Start with normal heart rate, getting that back into control, filling the tank, making sure that it's full. If both of those things were already normal, jump right into your squeeze and see what you can do. You have a neurogenic patient, heart rate is going to be low, so maybe we bring that up. That doesn't work. Their tank's full. We assess that, so that's not the issue. Move to the squeeze. So if you can move through this 4 steps, it's going to help you treat pretty much any type of shock. It might not tell you exactly what type of shock it is, but at least you can start treating. I mean, that's the whole goal, right? Is we want to give the best care to the patient as early as we can. And so using this can kind of help get you into the right direction. All right. Any questions? That is all we have for tonight's entertainment.